It is my pleasure to welcome Dr. Boukantar, an interventional cardiologist at the L'Hôpital Henri Mondot in France. Today, we'll be discussing his JACC interventions manuscript, a randomized controlled trial of non-fasting versus fasting before interventional coronary procedures, the TONIC trial. Dr. Boukantar, thank you so much for taking the time to join us and share your expertise.
Thank you very much for having me today. It's my pleasure and honor to be invited by a JACC cardiovascular intervention and to take part to this interview. Thank you very much.
Thank you. First, can you give us a brief background about the topic, the question, and the question that you and the team aimed to address and the population that you studied?
Yes, absolutely. So, as an interventional cardiologist, there is always the question of whether patients undergoing coronary interventions should fast or not before the procedure. We know that policies are different from institution to institution, with some requiring fasting since midnight, others since 6 hours before the procedure, and some not at all. We also know that there is not solid data in the literature, but we are aware that the SCIE 2021 recommendations suggest fasting for 6 hours for solids and 2 hours for clear liquids before the procedure. On my end, having been an interventional cardiologist for over 10 years, I've often questioned the true benefit of keeping patients fasting before coronary intervention, besides just making things complicated for everyone. I mean, sure, it's supposed to reduce the risk of aspiration pneumonia if something goes wrong during the procedure, but let's be real, those situations hardly ever happen, less than 1%, especially for non-urgent cases. So I thought, why not to do a study to show that letting patients eat and drink as they please is totally safe? That's why I designed the TONIC trial. We aimed to demonstrate that eating and drinking freely before coronary procedure was not inferior to the standard protocol of fasting 6 hours before coronary procedures. So regarding the population, all the population referred to our cath lab was a candidate for the trial. I mean, that there was no exclusion criteria based on the complexity of the procedure. All patients 18 years of age or older who were planned to undergo an elective or semi-urgent coronary procedure, it could be angiography, PCI, they all were screened and potential candidate to the trial.
Very nice. And as you mentioned, it's a very important topic that, affects everyday practice. Kind of moving more toward the design, and what endpoints were you and the team interested in investigating in this trial?
Yes, of course. So this was a prospective 2-arm parallel group randomized single-blind non-inferiority controlled trial. So this clinical trial was monocentric. As I told you, all the population referred to our cath lab for coronary procedure was candidate for the trial, except in case of emergency or combined procedure, for instance, coronary angio and TAVI. So patients were randomized before the coronary procedure in a 1:1 ratio to either a fasting group or a non-fasting group. Patients allocated to the non-fasting group were allowed to eat and drink at their convenience, while patients in the fasting group were told to fast for at least 6 hours for both solid food and liquid, which is our routine practice. The interventional staff performing the procedure was blinded to the group allocation. The coronary procedure, angiography and/or PCI, was performed in both groups as usual, predominantly with radial access, more than 90%. We wanted the primary endpoint to be a reflect of the usual complications we face in our daily practice, and those where fasting can have an impact. That's why the primary endpoint was a composite of vasovagal reaction, isolated nausea, vomiting, and hypoglycemia. The secondary endpoints evaluated safety with aspiration pneumonia and contrast-related acute kidney injury, and also satisfaction with the questionnaire.
Very nice, very nice. And I think, and especially like the endpoints, again, it reflects this question of this population. And Tell us more about the primary outcome. What did you guys found? What were the results from that?
Yeah, absolutely. So we are now diving into the most exciting part of the study. Sure. So regarding the population, we randomized 379 patients to the fasting group and 376 to the non-fasting group. There were 70% of outpatient and 30% of inpatients with similar baseline characteristics. 94% of procedures were elective, and we had 6% of NSTEMI. We had 70% of coronary angiogram with 20 to 30% of FFR during the coronary angiogram. And we had 30% of PCI with more than half, which were ad hoc PCI. Of the 222 PCI performed, 11% were CTO, 3% had high calcium burden requiring rotational atherectomy, and 9% included treatment of the left main coronary artery. So the main result is that primary outcome occurred in 8.2% in the non-fasting group and in 9.9% in the fasting group, with an absolute difference of minus 1.7%, which was below the pre-specified 4% non-inferiority margin. We also showed that non-inferiority of the non-fasting group to the fasting group with regard to the individual components of the primary composite outcome: hypoglycemia, isolated nausea or vomiting, and vasovagal reaction taken separately, both in the intention to treat and the per protocol population. An important thing for me is that in the subgroup analysis, the effect of the non-fasting intervention was consistent regardless of subgroup, with no significant interaction according to diabetes, sex, age, hospitalization status, use of moderate sedation, or the type of the procedure. So the results were huge.
Very nice, very nice. And just like you mentioned, the importance is the total population, and throughout the subgroups, you may maintain non-inferiority. What about the secondary outcomes? What did you find?
So the secondary outcomes were designed first to assess safety and second to assess patient satisfaction. Regarding safety, no differences between groups for contrast-induced acute kidney injury and aspiration pneumonia were found in safety analysis. Acute kidney injury occurred in less than 5% of patients, with typically a slight increase of serum level creatinine, and we had only 2 cases who needed an hospitalization for saline infusion. No adverse events related to food intake occurred. As for satisfaction, as expected, patients were significantly less hungry and less thirsty in the non-fasting group as compared to the fasting group. For future procedures, most patients, so 79%, would prefer free access to food and drinks over fasting, with higher values in the non-fasting group, probably because they just experienced improved comfort without added risk. Global satisfaction was not different, probably because eating or not is not the only one parameter in the perceived global satisfaction.
Very nice, very nice. And Dr. Bukantar, what's the message or the conclusion that you would like the audience to take away from this trial?
Yeah, so I think that the TONIC trial clearly demonstrates that coronary procedures can be safely performed without any period of fasting in all patients referred to the cath lab. Our study includes all profiles of patient. I mean, inpatient, outpatient, coronary angiogram, PCI, FFR, planned PCI, ad hoc PCI, complex PCI, etc. So I think that the results are applicable to all the patients we meet in our daily practice. So I believe this study will be a game changer, making the patient care easier. We will no longer need to worry about whether patients are fasting or not before our procedures. To be honest, I think that patients will be happier and so is the interventional cardiology team.
Yeah, I completely agree. And I think this sets a very good kind of start to hopefully changing these practices, you know, for because we know it's safe, and hopefully this will improve patients' quality during these procedures and after. And thank you again, Dr. Bukantar, for joining us today. And we invite everyone to go over the full manuscript published in this issue of JACC Interventions. Thank you again, Dr. Bukantar.
Yes, thank you again. Thank you very much for having me today again. It was my pleasure. Thank you very much.